So the question really is, why haven't we seen success in breast cancer like we've seen in other tumors with immune checkpoint inhibitors? And you know, the answer to that is fairly complicated. I think that one of the biggest reasons is probably that breast cancer is not that immunogenic a tumor as far as we know. There are fewer mutations in breast cancer, what we call neoantigen formation in breast cancer than in other cancers, number one. Number two, for whatever reason, you know, I think the big one is the fact that there's not enough antigens. It just doesn't stimulate that much of an immune response. I think it's interesting, you know, the tumors that really are very immunogenic are those that kind of where you interact most with the environment. For example, you know, melanoma is from your skin. Bladder cancer is from, you know, it interacts, you know, you have all the toxins that you're filtering out of your blood. Lung, you're breathing in smoke and other toxins. Kidney, you're filtering out things. So the thing is that it's really interesting that those are the tumors that seem to respond best and, you know, probably have the highest degree of antigenic diversity. And I think that's probably the biggest reason in breast cancer why that is. So, I mean, clearly we're doing a lot of monotherapy trials, a lot of phase 1B, phase 2 data right now that has modest activity, you know, response rates in the 12 to 20% range as a single agent. We have a few combination trials with nanoparticle paclitaxel with eribulin, various checkpoint inhibitors. And those trials, again, show response rates probably similar, maybe a little bit better than what you'd expect from the chemotherapy portion of them alone. I think there's a variety of ways that we're trying to stimulate the immune system. There's large phase 3 trials now of atezolizumab, which is a PD-1/L1 inhibitor, with nanoparticle paclitaxel. There are other large trials of carboplatin and gemcitabine in triple-negative breast cancer. There are also kind of thoughts about trying to use other agents, potentially, to stimulate the immune system. Specifically using PARP inhibitors in BRCA-associated breast cancer, number one, in combination with pembrolizumab. There's a trial that's about to start. There are other trials where, again, not only are we using chemotherapy, we're using other agents to increase PD-1, PD-1/L1 expression on tumors, so they're the MEK inhibitors now. We have a trial called the Colette trial, which is of a cobimetinib with paclitaxel that will probably be reported either at ASCO or San Antonio this year, and that's just with the cobimetinib alone. What we're doing actually is in that trial adding another cohort where we now give that cobimetinib and nanoparticle paclitaxel with atezolizumab. So we're actually trying that, and other groups around the country and world are doing the same thing, trying to add MEK inhibitors to this to try to boost up either PD-1/L1 expression or somehow boost up antigenic diversity. So those are kind of the approaches people are taking. Right now, the results of single agents are modest, but again, I think, as I said in my talk this morning here at Miami Breast, a lot of this is reminiscent of the early days of trastuzumab, of Herceptin, where we kind of saw modest activity as a single agent in heavily pretreated patients. So we'll see. I mean, you know, I'm cautiously optimistic. I just have to see where things go.